Good morning, everybody. Thank you, Beth, for having me here. Thank you, Dr. Kenny and Sharma, for inviting me back, and all of the conference organizers, and of course, you all for being here today. So I have no relevant disclosures for this talk. So I just want to show an article here that is pretty old at this point. And it's the last major step forward that we took in improving outcomes in cardiogenic shock. And this was the idea of doing primary PCI in the setting of cardiogenic shock to improve outcomes. And you can see that this is an old article now. This article is back in 1988, and it's pretty shocking that this is, like we said, the last major step forward we took in reducing mortality associated with cardiogenic shock. And also over this time span here, there's been a lot more focus on team-based cardiovascular care, heart team, but there wasn't really much talk about implementing this heart team specifically for the purposes of treating and caring for cardiogenic shock. And I think that changed a lot starting in 2019 when an article was published in JACC that looked at standardized team-based care for cardiogenic shock, and this was a single institutional study in Inova, which is in Virginia, and what they did was they developed a shock team in 2016. It was a team of dedicated specialists in cardiology that are focusing just on treating cardiogenic shock, and they developed their team in 2016. They identified 204 patients in shock who were cared for following the implementation of their team, and they examined outcomes compared with the historical risk-matched controls. And they found, not surprisingly, that a standardized team-based approach will improve cardiogenic shock outcomes. And this is the major data that they put, major graphic they put in their paper. And what this shows here is the outcomes associated with cardiogenic shock, the survival rates, both for ischemic-related cardiogenic shock, which is in the blue line, and standard non-ischemic cardiogenic shock, which is represented in the red line. And you could see before the implementation of their team, the survival rate for AMI-associated cardiogenic shock was 44%, and after the implementation of their team, it went up to as high as 82%. And a similar, though less robust, response was seen in the survival rates for non-ischemic cardiogenic shock. Prior to the implementation of the team, it was around 60%, and following the implementation of the team, it increased to 72%. So very, very big increase for what most consider a pretty simple change to the system. And after this was released, there was a lot of discussion amongst many different forums in cardiology about how the results that this paper published can be implemented and replicated in other centers. And people started, publishing very touchy-feely things on TCT. There is no I in shock team. They found some very dramatic graphics that represent a team taking care of a patient with cardiogenic shock. And they released this publication shortly thereafter, which talked about exactly how one could emulate this protocol as a way to replicate these results. And they published this article called Shock Teams and Shock Docs, which really gave a construct for how such a team should be designed and implemented. And there was one main thing that they emphasized, that there was a central shock team that takes referrals from outside centers and from inside the institution, and that they separated it based on these two categories of ischemic-related cardiogenic shock due to AMI and non-ischemic cardiogenic shock that has nothing to do with AMI. And these are distinctly different conditions to care for, as you all know, because in AMI cardiogenic shock, the priority is getting the patient to the cath lab as soon as possible, opening the artery as soon as possible. And for that reason, an interventional cardiologist is usually the team leader in these situations, coordinating a rapid lab response and rapid revascularization. For non-AMI cardiogenic shock, though, these are much different patients. While getting to the cath lab may be important for stabilization and right heart catheterization and insertion of mechanical circulatory support, it's much more important to have our heart failure colleagues involved and kind of take the lead on these cases, and that's what most people do. So this was another article that was published shortly after this. One of the criticisms of having a shock team, or the theoretical criticism of having a shock team, is that, well, now you have all these people having to talk at the same time about a very sick patient, and this must slow down care. So this article was published in response to that, and it was a similar study that they developed their shock team around the same time in 2015. Similar to the way Tarani did it, they identified 123 patients in shock following the implementation of the team, and they examined the outcomes compared with historical risk-matched controls. And they also showed an improvement of survival. But I think the more important thing in this paper was, like I said, the emphasis that using a team-based approach not only improves outcomes but has no real downsides. And to highlight that, they chose a secondary endpoint called shock to support time. And like I said, they were directly addressing the idea that having a team may slow down care. And they looked at the time from the time from when shock was identified until a mechanical circulatory support device was deployed if it was determined to be needed, and there was no delay, and actually there was a signal toward increased speed when this team-based approach was used. So no downsides, only improvement. So we aimed, along with Dr. Kinney, to emulate this protocol here at Mount Sinai, and we formed our own shock team in 2019. And there are 4 main members of the team that we use here that we have seen improved outcomes with. We have a dedicated CHF, advanced heart failure attending, who's dedicated to shock management. We have a dedicated interventional cardiology attending, a dedicated CT surgical attending, and also a dedicated cardiac ICU attending. And we have a protocol where if an outside institution or an inside person were to call our transfer center, we have a single line that is reserved for just cardiogenic shock calls, which is 1-833-MH shock. And the transfer center is trained to help identify whether or not the cardiogenic shock is related to an ischemic etiology or non-ischemic etiology. Like we said, very different conditions which require different team leaders. And if the case is non-ischemic, the CHF attendings becomes the team coordinator, while if the case is ischemic, the interventional attending becomes the team coordinator, again because of the importance on getting the patient to the lab as quickly as possible. All of the team members have a conference call with the referring attending about the patient at the same time, which really expedites care by allowing everybody to give input at the same time, everybody hearing about the case at the same time, so whatever resources need to be prepared can be done in anticipation of the patient arriving. And we try our best to keep a bed that is reserved for this purpose so that if we have an outside patient who needs to be transferred rapidly, that we have a dedicated bed in the cardiac ICU that the patient could be transferred to. So aside from this, this team-based approach, I think protocol-driven care is the other main thing that has helped people take a step forward in improving survival rates on these patients. And this is a very complicated algorithm that I don't want to go into in depth today because I think it's beyond the scope of what we need to address. But I think just recognizing and understanding that protocols like this exist, that having protocols like this that help us guide when mechanical circulatory support is needed and which device is best in a given scenario definitely helps expedite care and improve outcomes. And a similar protocol to this, probably the most well-known at this time, was developed in Detroit, which is called the National Cardiogenic Shock Initiative, and is a dedicated algorithm using some hemodynamic parameters to identify if and when we should use mechanical circulatory support, and again, which mechanical circulatory support is best in a given situation. So without going into the details of these protocols, I do want to emphasize what I think are the main things that make these protocols successful. And they emphasize 5 main things in my opinion. One is early recognition of shock. I think one of the things that we realized in caring for these patients that if you wait too long to activate the team, sometimes the patient can be too sick to rescue. So the earlier activation, the better. And that's synonymous and very closely related to number 2. The earlier shock could be identified, the earlier the team can be activated, the more likely that the team is able to be effective in resuscitating the patient. Mandatory use of right heart catheterization, I think, is an important central part of all of these protocols. There was a time when we were using right heart catheterization mostly to guide management of patients in medical intensive care units with medical conditions, and there was a lot of data that said, well, these catheters and the data that we're getting from these catheters are not that helpful in management of these patients. But these patients in cardiogenic shock specifically, are definitely a different patient subset. And the more that we're using right heart catheterization now, both subjectively and taking care of the patient, and objectively from data that has been published, definitely we're seeing improved outcomes with the use of right heart catheterization, and all of these protocols have right heart catheterization as a central part of decision making. Limiting uses of vasopressors and ionotropes, and what I mean by that is early institution of mechanical circulatory support. So even though it seems like using medicines like vasopressors and ionotropes are relatively low risk, we're learning more and more that the strain that it puts on the heart and the strain that it puts on the body can be a real negative sequela of the way we care for them. And so early institution of mechanical circulatory support as an alternative to high doses of vasopressors and inotropes is another central point that all of these protocols are emphasizing. And again, similar to that, rapid deployment of mechanical circulatory support when it's determined to be needed. And we're very familiar with door-to-balloon time, which is one of the metrics that we measure our effectiveness and efficiency with when it comes to STEMI. And now there's going to be a new metric that soon we'll be focusing on, which is door-to-support time. And if a patient comes in cardiogenic shock, yes, it's important to get them to the cath lab if it's a AMI. Yes, it's important to revascularize them promptly, but it's also important to promptly insert mechanical circulatory support if that's something that's needed, that's determined to be needed. And aiming for a similar metric of less than 90 minutes from the door is something that we're going to talk more and more about in the literature and practically speaking in the cath lab in the coming weeks and months. So I'm going to end a little bit early. There's time for questions if we need. And I just want to emphasize that even though it sounds simple, a team-based approach is a very effective tool to improving survival in cardiogenic shock. And early team activation and protocol-driven treatment, which is being continually developed now with all of the protocols that we mentioned, will lead to even greater benefit as they're perfected. So thank you very much. And if any questions, I'm happy to answer.